Welcome again to another talk on this series, Surgery for Undergraduates. Today's topic is another important and common situation that we see in our patients today. Okay, it is lower GI bleeding. First, let's define what is lower GI bleeding. Lower GI bleeding is bleeding coming from distal to the attachment of the ligament of Treats. Okay. This picture here shows you the attachment of the duodenum to the abdominal wall, posterior abdominal wall, and there's a ligament which attaches firmly to the posterior abdominal wall. Okay, it is attached to at the junction of the duodenojejunal junction. So at that area known as the DJ flexure, the ligament of Treats attaches it to the posterior abdominal wall. Any bleeding that occurs proximal to this ligament is considered upper GI bleeding, which I've discussed in detail in my last lecture. Bleeding that arises from the bowel distal to this ligament of Treats is defined as lower gastrointestinal bleeding. Okay, normally the normal fecal blood content is 1.2 mL per day. Significant loss is considered when there is at least 10 mL of blood in the stool per day. The most common feature or symptom of lower GI bleed is hematochezia, which is the passing of bright red blood in the stools. Again, this is a diagrammatic representation of the sources of bleeding from the various parts of the GI tract. Okay, so those highlighted in green are from the small bowel and the right side of the colon, which include angiodysplasia, diverticular, carcinoma of the cecum, where the bleeding is often occult, and bleeding from the Meckel's diverticulum. On the right here, we have got those conditions highlighted in purple, which involve the splenic flexure right until the rectosigmoid junction. These include the diverticula of the sigmoid colon, polyps in the descending and sigmoid colon, carcinoma of the descending and sigmoid colon, and ischemic colitis of the left-sided colon. Then, at the distal end of the lower GI tract, the rectum and anus will be acute inflammatory conditions such as Crohn's disease, which cause colitis. Okay, colitis as the cause of bleeding. Hemorrhoids as another cause of bleeding, which is lower down further, and another condition known as the solitary rectal ulcer. Besides that, there's also the anal fissure and other lesions in the anal canal, which can cause lower GI bleeding. What are the causes of lower GI bleeding? 95% of lower colonic bleeding comes from lower GI bleed comes from colonic bleeding, which includes diverticular disease of the colon, anorectal disease, hemorrhoid, anal fissures, fistula in anal, and solitary rectal ulcer. Neoplasia, polyps, ulcerated lesions of the colon, inflammatory bowel disease, and infectious colitis, angiodysplasias, which are venous or AV malformations in the bowel, radiation colitis and proctitis, and some other rare conditions. Small intestine bleeding accounts for 5% of lower GI bleeding, and among them will be angiodysplasia, Crohn's disease and infectious diseases, neoplasia of the small bowel, among which polyps are more common, radiation injury to the small bowel, Meckel's diverticulum at times can be a very major cause of bleeding, especially in children. Aortoenteric fistula, okay, is another cause of GI bleeding, and of course, mesenteric ischemia. This slide summarizes the common causes of lower GI bleeding in our patients. Diverticulosis of the colon, angiodysplasia of the colon, colorectal cancers, the various types of colitis, such as inflammatory, including infection, radiation colitis, and ischemic colitis. Anorectal causes, especially bleeding hemorrhoids, cancers of the anus, fissure in ano, and fistula in ano. Bleeding in stools. What are the symptoms of bleeding in stools? It is very important to get a very clear and detailed history of the bleeding in relationship to defecation in the patient. Is it initial or before defecation? If that is so, then the causes are usually external, like anal fissures, trauma, abscesses, and fistula in ano. At times, the bleeding can be terminal, that is after defecation, and this is classically seen in bleeding hemorrhoids. Very often, the stools are mixed with blood, or sometimes it is just frank bleeding, total hemorrhage. And these are usually due to causes higher up in the rectum and colon, such as tumors, vascular lesions such as angiodysplasia, polyps, etc. It is also very important to get to know the associated symptoms of this patient. Sometimes there is pain in passing with the blood, with the passage of blood, and this is usually due to anal fissures. They can be mixed, the stools and the blood can be mixed with mucus, which is commonly seen in inflammatory lesions, infections, and some tumors as well. Occasionally, the patient comes with severe abdominal symptoms like cramping pain, which is due to large amounts of blood in the lumen of the intestine, which causes severe pain. And lastly, they can have symptoms related to the primary cause, such as the cancer or some other disease which the patient may be having. Okay, this slide shows you some important features of this bleeding tendency. In hemorrhoids, bleeding after defecation is classical. Fresh blood drops on stools, spurting sometimes of blood, lump coming out of the anus associated with bleeding, and perianal discomfort. Okay, not so much of pain, more of discomfort. Anal fissure, the blood is fresh, strict on the stools, and it comes earlier before the stools comes out. And then it is associated with pain, sharp, severe, start with defecation and lasts for hours after defecation. In inflammatory bowel disease, the blood is mixed with mucus and diarrhea. It is usually painless unless coexists with fissure. Systemic symptoms and low-grade fever are also common in inflammatory bowel disease. Okay, what are the physical signs in patients with lower GI bleeding? First, external examination may reveal perianal conditions like anal tumors or growth over the anal region, fissures, or you can also have fistula in anal. Anal varices can also be seen externally. At times, thrombosed anal veins, fissures, and prolapse piles. Okay, these can be clearly examined by excluded by do a physical examination. Next, signs related to blood loss can be pallor, hypovolemia due to massive blood loss, abdominal distension due to large amount of blood into the lumen of the bowel, causing tenderness and distension. And rectal examination is a very important examination, together with proctoscopy, not only to look for to confirm the presence of blood, confirm presence of melena, and also any lesions in the rectum and anus. Then there can be signs related to the primary cause of the bleeding. For example, in the case of abdominal mass in the left side of the abdomen, to suggest it is bleeding from a tumor in the left colon, or it can have features of massive or weight loss and emaciation as a result of its tumor, or features, other features associated with the primary cause. At times it may be very difficult to distinguish between upper GI and lower GI bleed, especially when the bleeding is very massive. So the history and symptoms are very important in both the groups of patients. Okay, previous history will be of great help in diagnosing the source of bleeding at present. Okay, and then in the upper GI bleed, importance of medications should be considered. In the symptoms, upper GI bleed tend to have nausea, vomiting, hematemesis, and melena. Rarely they have hematochezia. Whereas in the lower GI bleed, hematochezia is the main symptom. Bleeding PR, especially fresh PR bleeding. And melena can occur, but is very much less common. Especially it occurs when the source of bleeding is in the higher small intestine. Abdominal pain can be a symptom of lower GI bleed, but it is quite rare. Next, we come to the investigations for patients with lower GI bleed. First, the routine investigations, which include the chest X-ray, blood analysis like the renal function test, liver function test, ECG, and also a full blood count, which should include a hematocrit, PCV, and hemoglobin to reveal the severity of the bleeding. At the same time, also the routine test will also give you a baseline investigation, as most of these patients are old and with pre-morbid medical conditions. The other investigations or special investigations include first endoscopy, okay, which includes colonoscopy and at times even a upper endoscopy OGDS to rule out upper GI bleeding. Colonoscopy has become the most important investigation in a patient with lower GI bleed. Okay, it not only helps in the diagnosis, the vast majority of cases, but it can also use therapeutically to treat or stop the bleeding in the GI tract. The next is the RBC scan or the technetium tagged RBC scan, which can detect as bleeding as low as 0.1 ml per minute. Okay, this is done in centers which have the facility to do, where the patient's RBC are tagged with technetium, and then a scan is taken to see the extravasation of this RBC into the lumen of the intestine, which are picked up on the scan. Next is angiogram. Angiogram is another important investigation, and it is also very accurate. 0.8 detects bleeding as low as 0.5 mL per minute. Okay, the principle of it is similar to the RBC scan, you're given the contrast into the patient intravenously or intra-arterially, and then films are taken to see where the extravasation of the contrast takes place. It can be done either as CT angiogram or direct catheter angiogram. CT angiogram is faster and more easily available and is less invasive, whereas a direct catheter is more accurate, and it is also can be therapeutic, where the bleeding can be stopped by embolizing the site of hemorrhage. And the last of these special investigations is the video capsule endoscopy, or the VCE, where it is done in only some centers. It may be quite costly. At the same time, it is takes time for the images to be analyzed, so it cannot be done in a dire emergency. Clinical assessment of a patient with lower GI bleed. First, as usual, the history is of paramount importance. The amount of bleeding, symptoms of blood loss like tired, giddiness, and breathless are all very important, and pain must be taken to get an accurate and detailed history from the patient or the relative. Next, the physical examination. Again, it's very important to assess the mental status, especially restlessness and confusion. Pale and lethargy is another important thing to be considered. The degree of pallor is very important. Breathless, cyanosis, they are all very important parameters in the clinical assessment of a patient with lower GI bleed. Then comes the pulse rate, the blood pressure, cold and clammy extremity must be assessed. All these are very important, and assessment must be completely done in the emergency department. Others, blood tests including hemoglobin level, renal and liver function tests, arterial blood gases, and chest X-ray are all important and must be done as soon as possible. The other important thing to assess is the pre-morbid conditions of the patient, especially the medical conditions and the drugs he is on. These are important because most of these patients with lower GI bleed are older or elderly patients, and they are prone to other problems of their pre-morbid conditions. Okay, this slide shows you a summary of the assessment of severity of bleeding in lower GI bleed. Okay, general condition of the patient, the degree of pallor, the pre-morbid conditions, and of particular importance is the age of the patient. The vital signs, the heart rate, blood pressure, pulse volume, and the arterial oxygen concentration. These are all very important parameters for the assessment of severity and prognosis of lower GI bleeding. These days, these parameters that are used to assess the severity of bleeding are given in some scoring systems. The two common ones are the Glasgow-Blatchford score and the Rockall score system. Okay, basically they use the parameters that we have all gone through. Okay, the blood pressure, heart rate, presentation, the syncope, the mental status, pre-existing diseases, the level of blood urea as an indicator of renal function, and also the hemoglobin. Okay, these are the parameters that they are taken into consideration to come up with a scoring system. The second one is the Rockall scoring system, okay, which is similar, which in this case it also takes into consideration the age of the patient, okay, the age and also the comorbidity of the patient, conditions of comorbidity, okay. So these are scoring systems that are currently being used in certain centers for a more objective assessment of the severity of bleeding. Okay, now come to the management of the patient. Okay, after assessing the severity, you have to decide on how to manage the patient. Okay, resuscitation is the most important in any case of bleeding. Doesn't matter whether it's lower GI, upper GI, or whatever cause of bleeding. This consists of replacement with IV fluids, crystalloids, colloids, or even blood transfusion if the need arises. There are others like Hemacell and Dextrans can also be used before the blood transfusion. Nasal oxygen, NG tube, and urine catheter are important things to be done for these patients on lower GI bleeding. Ideally, they must be nursed in a high dependency unit with close monitoring of the vital signs and arterial oxygen saturation. And at times, they may even need a central venous pressure monitoring if the patient is in shock. Treatment of lower GI bleeding. Endoscopy is a very important tool for the control of bleeding in lower GI bleeding. Once the bleeding points are identified, it can be ligated, or it can be clipped, cauterized, or even injected to stop further bleeding. It is done in large number of patients. Increasingly, more and more patients are being done with this type of treatment. Next is if the patient needs an angiogram. Once its bleeding site is detected, further embolism of the bleeding points can be undertaken to stop the bleeding. Various materials can be used to embolize and block the bleeding points. Surgery, especially open surgery, is at times required for open exploration and segmental resection of the bowel where the bleeding source point is. At times, we may need colectomy, total colectomy. In this respect, the Hartmann's procedure with colostomy is a very important procedure that must be considered. This is a diagrammatic representation of the Hartmann's procedure, which is the resection of the rectosigmoid colon with the closure of the rectal stump and formation of an end colostomy using the proximal stump of the descending colon. By doing so, the whole rectosigmoid colon is being removed, which bears the bleeding diverticulum, thereby arresting the bleeding as well. Time is given for this healing process to take place, after which the colostomy is taken down and the stump is re-anastomosed with the rectal stump, thereby closing the colostomy permanently. I shall now take you through some slides to demonstrate the lower GI bleeding. Okay, this slide is a case of colorectal cancer with bleeding. This is a diagram showing you diverticular disease of the colon, which occurs most commonly in the left side of the colon, the descending colon, and maximally at the sigmoid colon, where there are multiple holes are seen there, which are the outpocketing of the diverticula from the lumen of the bowel. Okay, these are the multiple diverticula that you see on colonoscopy. This is a close-up view. The important thing of this diverticulum is structure is the muscular wall that covers the rest of the colon does not extend into it. As a result, the wall is very thin and is prone to perforation, perforation of the diverticulum causing diverticulitis, and also the blood vessel that enters it becomes stretched over its dome, over the tip of the diverticulum. As a result, this can get eroded and cause massive bleeding. Okay, this is the pathogenesis of bleeding in a diverticular disease. Okay, here a colonoscope finding showing you the bleeding coming out from the mouth of the diverticulum. Okay, here it is stopped. So here it's easy. You can either to coagulate it or you can even clip it to stop the bleeding in emergency situations. Okay, this is a colonoscope picture of angiodysplasia in the right colon. Okay, the ascending colon. Abnormal veins, dilatation, which can cause rupture and cause bleeding. This is another patient. You can see so vascular, which can cause profuse bleeding. And this occurs in elderly patients. Okay, this next we come to mesenteric angiography other than after colonoscopy. This is a procedure where the bleeding rate of 0.5 to 1 mL per minute can be detected. Okay, so this is where the inferior mesenteric artery is being cannulated and the dye injected, and then you see the leakage, the arrow here, the leakage of the contrast into the lumen of the descending colon. Okay, selective angiography is done by catheterizing the arteries selectively under the fluoroscope guidance. Okay, in this case, you catheterize the inferior mesenteric artery, okay, to locate this bleeding. And therapeutic implication is done by embolization of the culprit vessel. So once you identify the bleeding vessel, you can embolize to block off the vessel and therefore stop the bleeding. This is mesenteric angiography. This is CT angiogram. This CT angiogram shows some leak of contrast into the descending colon. Okay, this is the descending colon. See, this arrow shows leakage of contrast. Similarly, this is another view showing you there's leakage of contrast into the descending colon on the left side. Okay, and in this is a case of bleeding from a colonic diverticula in the descending colon. Okay, another CT scan, different view showing you the leak of contrast into the descending colon on the left side. That means there is a bleeding point there. Okay, this is a technetium scan or technetium labeled RBC scan of a patient with some bleeding in the right ilia fossa region. Okay, probably in the cecum or in the descending colon. Okay, you infuse this patient's own blood with radioisotope tagged RBC, and then you scan the abdomen and look for the leakage of this tagged RBC. Okay, the site of leakage can then be detected on the scan and to help you to localize vaguely where the site of bleeding is. Okay, another angiogram. This is in this case is a superior mesenteric artery angiogram where probably the iliocolic artery there's a leak and there's a leak of contrast here. Okay, this again is in the right side of the abdomen, probably in the cecum or the ascending colon. Okay, in summary for these investigations, colonoscopy is the important examination and which must be done as soon as the patient is stable. Second is the visceral angiography, which needs more than 0.5 mils per minute of bleeding in order to be positive. It is 40 to 75% sensitive if it is bleeding at the time of examination. Then the tagged RBC scan can detect bleeding at 0.1 mil per minute, okay, which is much less than the angiogram. It is 85% sensitive if it is bleeding at that rate at the time of the examination. The drawback of this RBC scan is that it is not accurate in defining the left versus the right colon. The next investigations is one of the newer investigations known as capsule endoscopy or video capsule endoscopy, VCE. In this, the patient swallows a capsule which contains the camera, LED lights, microchip, batteries, and an antenna, transmitter antenna. It is a complete system of photographic system here. And then he swallows this, and this capsule travels throughout the intestinal tract from the mouth right until the anus. Then it is excreted in the stools. As it travels the gastrointestinal tract, it takes pictures, okay, and transmits through a sensor placed outside the body, maybe to the belt, strapped to the belt. So that means it takes a series of pictures which are recorded in these sensors, and then which are read after the patient passes the capsule out in his stools. The drawback of this system is one, it's expensive. Second, it is not widely available. And thirdly, interpretation takes time, and is not very useful for immediate bleeding. It is for more of a chronic or long-term investigation. Okay, this is the capsule the patient has swallowed. It has already reached the descending or sigmoid colon. And then it transmits pictures of the intestine. Okay, these are pictures of the small intestine which the capsule has transmitted to the receiver recorder. And this will then analyze, and this is a normal picture of the normal pictures of the small bowel. And this slide shows you the outline of the management of lower GI bleed. This is a simple and summarized to be understood by undergraduates. Clinical assessment and proctoscopy is very, very important to classify the bleeding into mild, moderate, or severe. Mild to moderate, you do a colonoscopy as early as possible, ASAP, okay, as soon as possible, when the patient is ready and the scope available. Okay. If it is negative, then you may want to do a RBC scan or a VCE. Okay. If it is positive, then you treat the lesion either endoscopically or surgically. And the surgery may involve either segmental resection or total colectomy, as the case may deem fit. In patients who are severe or life-threatening bleeding, as soon as the patient is stabilized, he is taken for a CT angiogram, which is the fastest and most readily available in many centers. Okay. If it is negative, CT angiogram is negative, then he's taken for an intraoperative or on the table colonoscopy done in the OD, and then decide on what type of surgery you may want to do for the patient. If the CT angiogram detects a possible bleeding site, then you may want to do vasopressing infusion to vasoconstrict the bleeding vessel, so thereby stop the bleeding. Failing which, you may want to do an embolization of the bleeding vessel to stop further bleeding. Okay, this slide, look before you flush, it could save your life, self-explanatory. I hope you find my short talk useful in understanding better the topic of lower gastrointestinal bleeding. Till I meet you again in another series, thank you.